I want to talk about the biology to support the all-inside suspensory fixation. And we'll go through the couple published studies on GraftLink that are out there with 2-year follow-up and share with you some results of a randomized controlled trial that I'm doing. So the all-inside technique we know is a quadrupled soft tissue graft, hamstring commonly. You can use allograft or quad. And the key is a suspensory tightrope fixation on both sides. I've been doing all-inside surgery since 2006, and always felt to me that on the tibial side, if we had that socket, we'd get blood and good growth factor accumulation on the graft to get better healing. I called it the potted plant. So the question was, how could we test and see if this was true? So we went to the animal lab at the University of Missouri. There's a vet school there, and Jimmy Cook helped me with this. And we just designed this model looking at suspensory versus screw fixation. The dog's a good model because of a double bundle ACL similar to human. The problem is the increased tibial slope of over 30 degrees tends to lead to failure in complete reconstructions. So I had a lot of double bundle experience in humans, so we translated this to the canine. We called it our hybrid double bundle. What we did is we cut the AM bundle in the dog, but left the PL bundle intact to preserve the joint, replaced the AM bundle with a graft. We studied this model because we had to prove that that reconstructed AM bundle actually saw load, and we proved that, and that was published in JOR in 2015. So then we went to our study group for the suspensory versus screw. We had 12 dogs, 6 and 6. We monitored them clinically. They were sacrificed at 12 weeks with arthroscopy at that time. Then we did biomechanical testing, and most importantly, the histology. So here's what it looks like. This is an interference screw case. You can see on the left side the implantation, the native PL is intact. We reconstructed the AM. And at 12 weeks, you can see it sacrificed. The AM bundle has healed nicely. This is a suspensory all-inside case, same thing. Native PL is intact. We replaced only the AM. You can see at 12 weeks, we've got good healing. So it looks like this schematically with the x-rays with the all-inside on the right side. Biomechanical testing, what we did then is we wanted to just test the grafts. We actually cut the native PL, so all we're going to test is the AM on the reconstructed side versus the normal limb, which was a complete ACL. And what we found is this, that you can see in this graph here, the control, the normal side's in the darker green, the suspensory all-inside group's in the yellow, and the light green is the screw group. We had higher suspensory, load was higher for suspensory than screw. None of the suspensories failed, one of the screws failed, and we were stiffer also. So we were pretty happy that our suspensory graft alone at 3 months had almost 50% strength of the intact control lead. So the key was the histology, and there were 2 pathologists looked at this, blinded, and what they graded the healing of graft to bone and found that it was statistically significantly better for the all-inside suspensory group versus the screw group, both on the femur and tibia. Here's a couple pictures going back to your basic science days. On the left, you can see the screw in place, the shadow of the absorbable screw, with a bit of graft on the right. With the suspensory, you see more graft in the socket, as you'd expect. This is the key, the histology. On the tunnel side, the full with the screw, all you basically saw was fibrous tissue to bone, no cross-linking at all. But on the all-inside suspensory group, what we saw was graft turning into cartilage to calcified cartilage to bone. So that's 4-zone integration, and that's normally how your ligaments attach in the body. We saw it only in the all-inside group, and we saw it on the femur and tibia. Then we looked at it a little closer, and if you look at this one on the left, at the aperture of the screw, you can see the shadow of the screw. There's not much graft there. If you look at the aperture on the all-inside, you can see quite a bit of tissue. So we broke this down and looked at this closer at the aperture. Scott Rodeo published that there was more motion with suspensory fixation at the aperture. We found exactly the opposite. We were statistically significantly better for the all-inside group at the aperture 0.05 in the middle of the tunnel, and only the base was the same. So we actually saw better healing, which to us means there was minimized motion with the all-inside suspensory technique. So what's in the literature with the all-inside published so far? First study they did with Jim Lubowitz and Randy Schwartzberg, we were just interested in pain. When we started doing this many years ago, we noticed our patients were much less painful. It was similar to the repair group. So we studied this in allografts. This was a randomized controlled study, 148 patients, greater than 2-year follow-up, 81%. What we found is statistically significant less pain with the all-inside group versus the full tunnel group. The second study that was really important for the GraftLink is what I would call the GraftLink precursor study that the 3 of us did. And what we did here is we wanted to compare a precursor of the GraftLink, which was button fixation. We used a retro button on the femur, and we actually just tied sutures on the tibia to a button. That was going to be our suspensory group versus aperture, screw on the femur, retro screw on the tibia. So we compared aperture fixation to suspensory in this group. This was level 2 because we only had 74% follow-up at 2 years. Here's what we found. No difference in KTs. Number 1, our outcome measures were the same. Our IKDC was really good for suspensory, and it was a bit better than aperture. And we had no tunnel widening, which was very encouraging. So what's been published? Sure's published last year, two-year follow-up. This was a GraftLink study, 79 patients. Again, their outcome measures all improved from baseline. KT 1000, 1.7 different. Did have a bit of a high re-rupture rate at 13%. Their average graft diameter here was just under 8. Adrian's group from England published this past year. 108 GraftLink patients, 4-year follow-up. Outcome measures were great. Side-to-side KT 2.4, re-rupture rate 6.5. The graft diameter was a bit over 8. So this is the study that I'm just getting ready to complete. It's a randomized controlled trial. We're looking at patellar tendon, the so-called gold standard, versus GraftLink semi-T. Although I do internal bracing, none of these were internally braced. 64 patients. I wanted to get the toughest crowd I could. So these are all under 25. These are all injured in sport. We have MRIs at a year on everybody, and every patient has completed SOS, which we're happy about. We have 100% compliance in this study group for this study. Here's our sutured construct. Again, there's no internal brace in this. This is just a quadrupled semi-T. 32 and 32. I lost 2 at 1 year, so I have 62 out of the 64 follow-up for 1 year. I have 48 complete follow-up at 2 years. We just have a few more to go. Average age of my group is 18. So young population. In this group, I have had 2 GraftLink failures. I've had no BTB failures, but I've had 2 of the BTB patients tear the other side in the 2-year period. So if you look at our IKDC objective, the GraftLinks, I have 26A and 1C grading, and BTB 22A so far. Side to side, exactly the same at 0.5. Pretty happy about the outcome of the GraftLink stability, equal to BTB. Here's a representative MRI. You can see kind of the potted plant on the left, the GraftLink, versus the screw in place with the BTB. So just putting it together, looking at the works, that's the 2 that were published last year, kind of side to side. My average graft diameter for my GraftLink group was 8.8. Re-rupture rate is 6.67, which I think compares extremely well since these were average age of 18. And we've heard, the risk of re-rupture in that age group is up to 30% in some recent published studies. So the GraftLinks have held up well. The KTs are very good. And again, I had a very young study population here. In terms of the data, looking at it, SF12 that we studied were statistically better than baseline for both BTB and GraftLink. GraftLink is in the yellow here, BTB is in white. GraftLink just about exactly the same. When you look at IKD subjective, GraftLink trends to be a little bit better, but there's no statistical difference there. We looked at that in the 48 that we have. Same thing with KOOS, a little bit better with GraftLink, but not statistically significant. Both are, of course, better than baseline. Mark's activity score is interesting. Pre-op exactly the same at 15. Post-op a year, we have 13 and 13. So it's not back to 15. So I think a lot of us that take care of these high-level athletes know that at a year, they're really not back 100%. So we'll see where the final marks is at 2 years. Hopefully we'll see some improvement there. So what also is interested in is SOS. Again, all my patients have collected, and I don't think anybody has done any validation of SOS yet to in-house data. So what we're doing in this study is all the patients are back in my office at 2 years. They get an x-ray. They fill out all their paperwork. So what I did here is we correlated what they filled out on the computer versus what I found in-house, trying to validate SOS. And here's the SF12 physical. So you can see SOS in this slide is yellow. In-house collection data is white. Basically the same. No statistical difference. We looked at that. KOOS, same thing. Pretty much exactly the same. So what we got off online matched what I found in the office. Quality of life with KOOS, about the same thing. And the Mark's activity, pretty much the same. So this is exciting for me, so that this cohort of patients, hopefully when they're 3, 5, 10, 15 years out, I'm going to go back with them on SOS, because if it correlates as it has here, that should allow me to get that data and publish it and not necessarily have them come back to the office. So I think the validation of SOS as part of my data here would be very important. So in conclusion, the basic science supports better graft-to-bone integration with a suspensory all-inside construct, especially in relation to screw fixation. The published clinical studies so far have showed excellent patient outcome scores, good KT 1000 numbers. This randomized controlled trial that I'm completing versus BTB in young athletes, average of age 18, looks very good so far for GraftLink, comparable to BTB.